Happy Saturday, everyone, and welcome. My name is Marissa Thomas. Some of you may know me. I am the co-founder of For the Breast of Us, the first online community that is inclusive to all women of color who have been affected by breast cancer. Today, we will be talking about amplifying the voices of survivors and thrivers of color. We invite you to join in on the conversation with us. Turn your cameras on if you feel comfortable. Point any questions that you may have for our panelists today in the chat, and we will definitely answer those while we are speaking. But today, both of our speakers that we have are the lovely Ricki Fairley and the amazing Dr. Mo, and they're going to start off our conversation today. So again, if you have any questions, please let us know. They'll be happy to chat with you and answer those. And I'm going to let these two beautiful ladies take this away.
Wow. Well, thank you. Thank you so much. I'm Dr. Monique. I am a breast surgical oncologist, a breast cancer surgeon in Pennsylvania, actually the only Black female breast cancer surgeon in the state of Pennsylvania, serving over 11 million people. And I am the proud medical advisor and co-host of The Doctor Is In with Ricki Fairley, who is joining me today. I love that backdrop, Ricki. How you doing?
Hey, Doc, I have one for you. I have one for you. It's so great to be here. It's so great to, have this opportunity to talk to more women about breast health and, talk to more breasties. And I'm excited to talk about this topic, which we talk about a lot, Dr. Mo, and we cannot amplify our voices enough. We cannot.
We do talk about it quite a bit. And I think that it's something that is a great topic for today's session, because when we talk about amplifying the voices of particularly young breasties and especially young breasties of color, I think we have to talk about the ways in which the voices are not amplified, because you don't know until you get this diagnosis. And I can't tell you the number of young women that I've seen with breast cancer who go to their doctors, and their doctors, they say, oh, I have a lump, or I have breast pain. The doctor says, oh, it's fibrocystic, or, oh, you just have a cyst. Yep, that right there, that's a cyst. And they don't do any imaging, and they don't do any workup. And, I think that if people take away nothing else from today, I hope that it would be learning to ask your doctors the following questions. How can we be sure? Is there anything else we should do? Right? Those are unassuming things to say. You don't have to feel confrontational with your doctor. And we talk a lot about, firing your doctor and all these things and partnering with your doctor, but there's a way to have these conversations, because what we find are that young women get turned away, and the lump persists, and then it grows, and we end up with more advanced disease. So, I wonder if you could speak to that, and what are we seeing in the country and really in the world as it relates to young breast cancer?
Well, the data says that Black women under the age of 35 get breast cancer at twice the rate and die at 3 times the rate. Unacceptable. And dismissal from a doctor is not an option. And, Mo, I always say, and, I learned this from you, Mo. Remember, we had one of your patients on the show, and she said the first thing that you said to her is, I'm going to treat you like family. Mm-hmm. And so, and that's so important. And so even when people are feeling challenged by their doctor, uncomfortable, or given choices they may not understand, I always say, tell the doctor, give me the choice. Like, what would you do for your own kid? What would you do for your own daughter? What would you do for your mom? What would you do for your sister? And that's the care I want. I want the care that you're going to give to someone that you love, and demand that from them. And I think that's what makes you so awesome, Mo, because that's what you do. You treat people like they're family, and every doctor should. And we know that they're rushed. They don't have a lot of time, and they don't, they can't really take the time, and they throw this information out at you. And even with COVID, you may be alone and not even have the wherewithal, because you don't feel where you're scared, you're petrified, you're, not feeling great to even ask the questions. But just say, treat me like you would treat, the golden rule. Treat me like how you want to be treated, how you would treat someone that you love. And give me that care.
I'll take it a step further, because I've graduated from the golden rule to the platinum rule, which is not just treat you how I want to be treated, but treat you how you want to be treated, right? Mm-hmm. Because that transcends everything, because it now covers a multitude of patients who aren't like me, who may have different needs and different wishes and
Right.
different desires. And, you know, just to give people a little bit of background about what happens in medical training, because I think that people don't really know. You watch Grey's Anatomy, ER, and you think you know what it is to become a doctor, right? But there is this process of learning and unlearning that happens, whereby doctors are trained to chisel down using the information in front of them, chisel down the possibilities quickly. And it's pattern recognition, right? And so it's saying, okay, this is the common things. These are the common, these are the things, and you start to learn how to make assumptions, make these connections in your head, these shortcuts, mental shortcuts. We all do it. It is something that evolutionarily people are trained to do. Doctors practice this skill of making these mental shortcuts to try to get to a diagnosis fast, because in certain instances, emergencies especially, you got to move quickly. So you got to be able to figure out what it is and what it isn't. And that process has to be unlearned now. Because when we see, especially young women who have a breast concern, you know, it may not be on that doctor's radar. I'm talking primary care, I'm talking gynecologists, I'm talking surgeons even, you know, and so those of us who are in that breast cancer space, we're more and more aware of it. But the ones who aren't, the ones who are dealing with hypertension and flu and COVID all day long, you got a breast lump and they see it, they're like, you know, you're young. Chances are common things common.
Right.
And that's why it's so important, I think, to speak up and to put the pause right there. Because if you can intervene in that doctor's thought process, it's not that they don't want to help you. It's not that they're not listening to you all the time. It's that their mind has made this shortcut that says, of all the common things, this probably isn't it. And that's where you can start advocating for yourself and say, hey, I know this isn't the most common thing, but did you know I have a family history? But are we going to do some imaging here? I mean, you don't have a magic 8-ball. How do you know what's going on in here? Can we not just assume? But pause. What if I were your daughter? What if I were your sister? And I think when you do that with doctors, it reminds them and it pulls them back from this theoretical world of calculation, who's coming in the door next? What am I doing? And it says, okay, stop and treat the person in front of you. And not every doctor does that all the time. Not every person does it all the time. We see people and we make assumptions all the time. And so in an instance that's critical like this, like your breast, like your health, like your life, because it's not just at the diagnosis, right? Because once you get diagnosed, now you've got, okay, you get through your treatment, right? You get through your scans, you get through your treatment, you get through everything. And now it's like the scanxiety. And now it's, well, I have a pain. Now it's, hey, I don't feel good. My energy level's not good. How do we know nothing's going on? And so that's a tough conversation, because there is such thing as scanxiety. It's like anxiety, but it's about scans, right? Every headache, every pain, everything is like, oh God, is this the cancer? And so now you as the patient, you got to balance this, and you got to balance this with fear and anxiety versus data versus, you know, partnering with your doctor. And that is where it's so important to form that relationship and be able to speak up for yourself. And so when we talk about amplifying voices, Ricki, one of the first things you said before we jumped on this Zoom, she said, I think that we all need to realize that we got to amplify our voices in our own situations before we can amplify it nationally or anywhere else, right?
Right. We have to take care of ourselves. And a lot of it, and this is even a little more pre-diagnosis, is knowing your body. You know, we know our bodies better than a doctor does. We live with them every day. And so, you know, when something doesn't feel right, and you know, so that's sort of pre-diagnosis. So check your breast, check your body, stand in front of the mirror, look at yourselves. But so once you've got a diagnosis, then you start to figure out, you know, I don't really know what chemo feels like. So I don't know my body now, because it's a different animal, it's a different body, but still be in touch with it. And so, you know, when something doesn't feel right, and it's okay to ask. I have so many breasties call me and say, well, I've got this pain, or I've got this thing, or I just can't stop vomiting, or whatever. You know, there's drugs for everything, not just chemo. So, you know, doctors like you have solutions for things that are side effects. It's okay to call a doctor and say, I'm having this, whatever side effect, I'm having this feeling that doesn't feel right. And it's okay to ask for that. It's okay to ask for it's okay. You don't, you know, the doctor is not God, and no one knows how you feel except for you. And you've got to, you know, basically, you know, put your big girl shoes on and big girl panties on and say, help me, I'm not feeling well. And there's normally a solution for it. You know, there are not too many things that we can't try to have some kind of relief for with a side effect. But even jumping over to sort of amplifying your voice as an advocate, Mo, and I think, you know, we should talk about that. You know,
Well,
I think
Ricki, Ricki, do you mind before we jump into
yeah,
that? I know
yeah,
that
yeah.
there's two questions here for Dr. Mo. And so the first one, Dr. Mo, was, do you see a difference between the onco providers versus the PCPs when dismissing younger patients who complain about breast pain or express concerns?
You know, I wish that I did. I see the same outcome for different reasons. So I see the PCP may say, oh, it's probably just fibrocystic, and you know, they may send you to the breast surgeon, right? And just to sort of cover their bases because they don't really know, and they do the breast exam, and you know how doctors do. They're like, you have dense breast, see you later. And you're like, well, what does that mean? What even is dense breast? So then you go see, let's say the surgeon. I get a lot of patients in my practice with breast pain, and you know where they end up? They end up with my nurse practitioner, right? Because I'm the surgeon. So we're looking at people who need surgeries, who get sort of priority over people who have a lump that hasn't had imaging, or a young person with a lump. And so here's a difference also, not that a nurse practitioner isn't a great resource, but I check in with my NP, right? And so we talk, we collaborate about the young patients that she might be seeing. And if she's concerned, one, she knows how to use an ultrasound. And not every surgeon, not every doctor does. And we got one in our office. So if she's got a patient with a lump and she didn't ultrasound it, I'm going to call her and be like, well, how do we know? Did you do an ultrasound? You know, and that is a difference. So when you go to see a surgeon and you don't have a surgical issue, sometimes you still get somewhat disregarded. And that's why I said it's important for you to speak up. And you got to be like, okay, pause. I realize that this might not be a cancer. It might not be a surgery for you, but still, I need some reassurances. And a couple of things you bring with you. One, you bring with you your own personal knowledge of what's going on. So if you're like, I don't know if it's been there 2 days or 2 weeks, I don't know if it's bigger. I don't know if it changes with my cycle. I have no idea. And I don't know my family history. Then it gets a little bit tougher. And so you've got to sort of be a historian as best as you can to help guide that conversation. And then again, when all fails, like the fail safe, you know, when you're on that high wire, the net below is okay, taking all this into consideration, everything I know, everything I don't know, because I might not know my breast. I got lumps everywhere. What would you do if I were your daughter? What would you do if I were your sister? Right. And, you know, if that's what you think, I appreciate your judgment, but how can we be sure? Is there some follow-up? Can I see you again in 3 months? Like, what are we doing here for this? You just gonna send me out in the breeze? Because when I see patients and I think they have nothing, 9 times out of 10, I want to see them again in 6 months, just to make sure that my suspicion and my diagnosis of nothing is truly nothing. Mm-hmm. And so, and then I tell them what to watch out for. So that's another question to put down on your list. Right. What do I need to look out for? How do I know when to call you again? How do we know if this is whatever? And that doctor should be able to tell you what to look for if things are resolving, if things are getting worse. If this is likely to be cancer, this is what's going to happen to you. You're going to feel this is going to persist. It might get bigger. Your skin could change. You could have nipple discharge, you know, but before you even get to those things, I want to see you back in 3 months. I want to see you back in 6 months. And let's just make sure. And there's no harm in that question of how can we make sure? Right. So to the person who asked that question, it goes both ways. And it's not just, it's I promise you, it's not just racial, because I see a question in the chat about race, right? How do I talk to my white doctors and so forth? It is the fact that you are young and the fact that young women have fibrocystic breasts. And so just to give a real quick education about fibrocystic breasts, the breast, when a doctor says you have dense breasts after the exam, that means they feel thick. They feel doughy. They feel lumpier. They don't feel as fatty. Think pizza dough, right? Dough is kind of dense and sort of thick uniformly, right? And so what that means on the imaging is it's the white stuff on the mammogram. It's like snow on the TV, on the console TV screen. I'm showing my age. So you got a lot of static on your TV screen. That's the density. And so that density is like a natural sponge, not like a cute little kitchen sponge, not the cute little Ocello, but like a loofah, right? Mm-hmm. And so some women have a lot of fibers and little tiny holes, and that their breast feels thicker because they got a lot of fibers. Some women have a lot of holes and not a lot of fibers, and that their breasts are fattier, and they get more cysts and things. And so the texture of the breast can be different in young women. They got a lot of fibers and little tiny holes that feel like little caviars and little bubble wraps and little, you know, lots of little lumps everywhere. And so doctors are banking on the fact that all those little lumps are just cysts that come and go with menstrual cycle, salty food, fatty food, hormonal changes, who pisses you off, what day of the week it is, what cycles of the moon are doing, like they swell and recede like the tide, right? This is what young women's breasts do. And that's why it's so hard to detect. But that's how you also could say, okay, but because my breasts are so lumpy, how can we be sure?
Yeah.
So,
leading into the advocacy perspective, we have another question in the chat here where it says, I'm 30 with triple negative breast cancer, negative genetics.
God bless you.
How do I advocate for my younger sisters to get monitored early? What does insurance allow? And I think either one of you can answer that.
Sure. You can advocate for anything. I mean, you just ask the question and demand it. And, triple negative is interesting because I had TNBC and I don't have any genetic mutations, but I know there's got to be something about our Black bodies that make our bodies different that we haven't figured out yet, which is a whole nother conversation about clinical trials. But I do believe there's a connection in families. We don't know. We don't have any data to support that, but you have to ask, and you have to go to your doctor and ask for your sisters to get checked. And, normally I think the kind of the protocol now is to get a risk assessment if you have a history with at age 25, but if you got at 30, sweetie, they should be getting their risk assessment probably, what do you say, Mo, 10 years earlier, right? At least 10 years earlier at 20. So
years younger than the youngest person in the family.
Yep. So, I would say just demand that the doctor, check them out and protect them, because, we can't prevent it, but we can definitely early detect it, and they can make some decisions on their behalf that could change their life, and change their health. So I would just ask. And if one doctor doesn't respond, go to another doctor. And frankly, mammograms are free, so based on Obamacare, but you can, just fight with your insurance company, and really the doctor can do that. The doctor can advocate for you to the insurance company. Yeah. And if you need help, call me. I will help you. I'll put my number. Can somebody put my number in the chat, because I can't chat right now? It's 443-758. What's the rest? I got to think of my phone number. I'll put in the chat. Wait, 443-758-1924. Thank you.
There you go.
Let
me jump in. Let me jump in and say a couple things. And the first thing is that this is a great time to, again, talk about, to the best of your ability, knowing your family history. And I know that's not always possible. Like my mom had ovarian cancer, 29. I didn't find out until I was almost 29 what she died from. And she died before 30. Like, come on. We didn't talk about it. It was something down there, and it was a horrible thing in our family, and nobody wanted to mention it, but it's like a really important thing, because ovarian cancer is less than 1% of the population. Like, I could have had a BRCA mutation, and my grandmother had breast cancer twice, right? And so, one, starting to have those conversations with family, it's always a good time for it. Two, as far as the screening and the diagnosis, so screening for young women is not necessarily indicated, approved, covered by insurance unless you got that family history, right? Because then we know, okay, if you got a family history of breast cancer at 40, you start at 30. If you got a family history at 35, you start at 25, and it puts you in a higher risk category. One, to get ultrasounds, to get mammograms, to get MRIs, because that's where insurance companies get a little funky about it, because MRIs are expensive, right? Yeah. And so somebody needs to be doing a risk calculator, and I'll put them in the chat. There's a couple different ones that you can do, and you can download these on your computer. You can plug in your own family history and your own weight, and your own age, at whatever, when you started your period and when did you have your first child. All that stuff goes into a calculation, and doctors can do this calculation, and they can tell you your 10-year and your lifetime risk of breast cancer. And if your number is greater than 20%, whether you got family history or not, then you're somebody who should be getting screened earlier, and that helps insurance to pay for those things. Now, on the diagnostic side of things, because that's different. Diagnostic means you got nipple discharge, you felt the lump, you did whatever. Right. Insurance should cover that. Now, your copay, your deductible, that's a different story, because deductible, if you got a high deductible plan, then that's where you're going to fall into some challenges, but you should not let that stop you. Many hospitals have charity care programs and other things that can help to sort of wheedle away at some of those costs. So the diagnostic imaging you need to get. And this has been a problem, because women have waited. They pushed off their screening because we told them to, right? Which was unfortunate, because now I'm seeing a lot of women getting screened later because of COVID.
Right.
And two, women who needed diagnostic imaging, felt a lump, had nipple discharge, they had blood, they had skin changes, something going on. They waited and they waited and they waited. And now I'm seeing women with more advanced disease because they didn't get their diagnostic imaging because they said, oh, well, they said I shouldn't go in for my screening. That's not the same thing.
That's not the same thing. No, it's
Right.
not the same thing.
Diagnostic imaging means you do not pass go, you do not collect $200, you go get the imaging to figure out what's going on, COVID or no COVID. And so diagnostic imaging should be covered. Now, one more thing I'll say as far as advocacy, there is not enough legislation right now surrounding young women with breast cancer. And that is an area where we can all get more involved, because when you look at what the legislative agenda is, they didn't pass something for a stamp, something about a coin, something for the Early Detection Act that's going to give some money, maybe 9 million or some dollars or something, but there's not a lot of early detection for younger women legislation. And that's something that we need to change. We as in this group in this room.
Yeah, because it's different for young Black women. It's really different. We have a different disease. You know, Black breast cancer is a different disease and needs different consideration. So, but you know, my motto is, you know, no is never the answer. It's always how. So we will figure it out. Like if you need help, we will try to help you figure it out. Just keep, you know, knocking on doors and calling people and, you know, being the squeaky wheel, and you can get help. And I will help you do that. We will help you do that. That's what we do. So
it's true, because if you dial that number, she's going to text me about you, and then I'll
exactly. I am.
That's how this works.
I'm going to text her at 2 in the morning. I'm going to text her at 2 in the morning, and she's going to text me right back at 2:15.
So speaking of family history, Dr. Mo or Ricki, what is considered family history according to insurance companies or doctors?
Go, Mo.
Okay, so depends on which doctors you go to, but they should all be asking about first generation, second generation, even third generation. What I mean by that: first generation, mother, father, sister, brother, right? Immediate family. Second generation, grandparents, aunties. Third generation, cousins. And so if they're not asking about all these things, like on my intake form, when you come see me there, I want to know every family member on both sides of the family, because there's this myth that it only matters what's on mom's side, right? And we talk about BRCA mutations and all those other things. And I've had patients come in and say, oh, on my dad's side, that doesn't matter. And meanwhile, dad's sister had breast cancer, dad's dad had breast cancer, dad's mother had breast cancer, and that's where the mutation is. I'm finding more and more people who have mutations that came through on dad's side of the family.
Like Beyonce.
Exactly, Matthew Knowles, right? And here's the thing: only up to 8%, 0 to 8% of men with a BRCA mutation will get breast cancer, which means 92% of men who have that mutation won't get breast cancer, and they have no ovaries.
Right.
So they're just passing it to their kids. Right? And only 20% of them will get prostate cancer. So 80% of these men have a mutation and they don't get any cancers, and they pass it to their daughters and to their sons. So both sides of the family, all three generations. Now, as far as what insurance will cover, some insurances like Aetna, and others won't cover second and third generations for things like MRIs. But that's where that risk calculator comes in. And I'm looking for the link. I'm going to put it in the chat. And I wish I could put it up and share my screen with you, because if I could share my screen, I would show you that this risk calculator is something that you too can download and
fill out. Yeah. Yeah.
I will say, just for myself, I was diagnosed at the age of 35. I have a genetic mutation that I received from my dad. My dad has 17 brothers and sisters, and at least half of them have passed away from some sort of cancer. And the genetic mutation that we found out that we have, which I found out about 5 years before I was diagnosed, is Lynch syndrome. And when I was diagnosed, I remember telling my doctors, I'm pretty sure that this genetic mutation has something to do with me getting breast cancer, because I have no history on my mom's side of it. So this has to come from somewhere. And I remember all the doctors telling me like, oh, there's not enough research. And I'm like, well, research me, research me. I'm right here. Just research me.
Right.
And now there are studies that are coming out that's saying that there is some link in between Lynch syndrome and, you know, breast cancer. So I would say, as Ricki and Dr. Mo have been saying most of the session, it's definitely push your doctors, ask them to have, you know, particular testing done. And when it comes to family history, once you find out that family history, if nobody else does it for you, write it down yourself and take it with you to your medical appointments, because it's so important for your doctors to have that information and for them to help you direct your care.
Yeah.
I think the other thing too, Marissa, is we need to talk about it. And we brought this up earlier, Black people don't talk about health, don't talk about it, and so to me, breast health should be what I call kitchen table conversation. It's like going to the dentist, like getting a checkup. It's like everything. So with your sisters, if you got to, help them understand how to check their breast, make sure everybody's doing it properly, and talk about it. Talk about it at the breakfast table, talk about the dinner table, talk about it in front of the men in your family, talk about it with everybody. Like, it should be a common, comfortable conversation. And put it all out there, because everybody needs to. I always say, check the breasts that you love. I know you have a pair, whether you're a man or a woman. So, right. So everybody it should be a comfortable, everyday conversation. Like, you talk about anything. And that way people are protected, because they're checking their breasts and they're knowing their bodies, and it's okay. It's okay. It's not anything hidden, like Mo experienced as a child,
Yeah, I definitely agree with you, because genetic testing is now becoming more ubiquitous, because the companies are, we're collecting a lot of data. We're finding out that there are more people who have mutations than previously thought. And this is something to talk about with your loved ones and your older relatives as well, because, women who were diagnosed in the 90s and 2000s, especially Black and brown women, were not necessarily offered genetic testing. And they meet that criteria. They were diagnosed at 40, 42, 45, 35. And their doctor said, well, let's just deal with what's in front of us. That testing is expensive. It's $3,000. Your insurance is going to pay for it. And they didn't do it. And so now those people are in their 60s, 70s, and 80s, but they had cancer in their 40s and their 50s, and they meet that criteria now. By criteria, I mean the cancer guidelines are called nccn.org. That's the website, nccn.org. And you can look for the guidelines for how we manage, diagnose, treat cancers. The guidelines have now expanded to include so many more women, and those women didn't get tested way back when. So your nana, your grandmother, your mom who didn't get that testing can now get that testing. And hereditary cancer testing is spit in a tube. They send it to the company, run it. They can draw your blood, but it is super, super easy. And it's something that, they should be offering to you. So even the PCPs, the gynecologists, the surgeons should all be asking about that family history to figure out if you could have a mutation in the family, because what we know from the data so far is that Black women tend to have the same rate of hereditary mutations as white women, which is about, it's about less than 10%, 5 to 10% of all cancers are hereditary. And what I mean by that is that there's a mutation that got passed to you versus genetic. All cancer is genetic. And you should learn to speak the language as you grow in your advocacy of things like genetic versus genomic. What is your subtype of breast cancer? ER, PR positive, HER2 positive, HER2 negative, triple negative. Like, learn those things, because a lot of us don't quite fully understand it, and you will be a person who can help to advocate and help to navigate your friends and your family members when you understand that the different subtypes of cancer the treatments are based on the subtypes.
Yeah. Before, I know we're getting close to close, I just wanted to talk a little bit about just the whole Amplify Your Voice as an advocate. And you guys call me, reach out, and we can talk about it, after the fact. But just find your purpose. And, we always say that our triple negative breast cancer patients, we say, no one fights alone. And you can't imagine the power that your story has for another breastie. And so many of the calls we get are about, well, the doctor said this, but Ricki, what do you think? Or do you know anyone who felt this? And so advocacy starts with just helping one other breastie, helping somebody in your family, and just share your stories and tell people what you experience, so that we can all learn from each other. The breastie love thing is very powerful and strong. And that's what an advocate is. You amplify your voice by just talking to another breastie and helping her through.
Yeah, and I know we have
Definitely agree.
Yeah, one other question that I just sent to Dr. Mo, but I'll ask real quick before, and it's about COVID vaccines. So someone asked, I'm almost 5 years NED and taking tamoxifen. I'm concerned about interactions and side effects. 45 years old, ER positive, PR negative, HER2 positive, stage 2B, chemo, double mastectomy, radiation and reconstruction, 7 lymph nodes, including a sentinel node. So any thoughts on that, Dr. Mo?
Yes, absolutely. So done a lot of research on the COVID vaccines. I got mine, I got Pfizer. And for our breasties, if you get your vaccine, you should get it in the opposite arm as the side you had lymph nodes removed, even if there's only one lymph node removed. If you've had it on both sides, you know, if you've had bilateral cancer or lymph nodes removed on both sides, talk to your doctor about it. I've heard of people getting it in the buttocks. I'm not a fan of that. I probably would not do that there. But if you are questioning whether or not you should get it because you're thinking your immune system could be compromised, one, if you are out of active treatment, your immune system should have enough time to rebound. So the recommendation from Society of Breast Surgeons and others is that at least 4 weeks out of active treatment, right? So you finished your chemo, you finished your radiation, et cetera, really 2 to 4 weeks. The vaccine itself does not knock down your immune system. It actually boosts and it primes your immune system. So it's not going to make you compromised. And that's a really important thing to know, because the way it works is the mRNA and the adenovirus ones, they take the spike off the corona. So the corona is shaped like this with all these spikes, right? And so it cuts one of the spikes off and it presents it to the body, almost like showing a wanted poster. Like, okay, see, if you see this guy with the red hat on, don't let him in the club, right? And so then your body takes in the spike and it passes it around to the cells and says, okay, if you see this guy with the red hat, don't let him in the club. And now everybody recognizes the spike on the virus. So it's not giving you the virus. And then the next injection, if you get the second one, gives you the spike and it says, okay, here it is. And your body should respond. And that's why you kind of mount a little bit of a response to it, because your body's like, uh-oh, there's that red hat, get it out of here. And so it proves that the immunity is working. So I am a fan of it, because we know that cancer patients, especially those in active treatment, are almost 50% more likely to have really severe side effects of COVID. That's a huge number, you know, and you know what happens when we go into a hospital, you're having shortness of breath, you got all these other things going on, and you don't know if it's cancer, if it's the chemo side effects, if it's whatever. And so I think that it's important to do your research, talk to your doctors, and to consider it. You know, I'm not here to tell people what to do with their bodies, but I do know that it's been safe. I do know that a number of cancer patients have gotten the vaccine, even though they weren't necessarily included in the original trials. There are studies going on now that are looking at it. I know that it's not going to give you the coronavirus, and that it really is going to just help your body to recognize it. The reason they don't want people in active treatment to get it is because they're worried that you won't mount any response and you got a vaccine for nothing. Because if your immune system's compromised, then you're not going to mount the response, and you just, you know, put something in your arm and it's not going to respond to it. So that's the reason why if you're in active chemo, you probably should wait until 2 weeks after the last treatment, or until you're done with your chemo.
Yeah. Well, thank you, Dr. Mo. And thank you, Ricki. I know our time went by really, really fast, and it's a great conversation for us to have. I'm sad that we can't continue it. I hope everybody here learned something to take away. And in the chat, you've seen we had put in some information. So thank you for joining us. We appreciate you.
Thank you. Thank you so much, Marissa. Thanks, Dr. Mo.
Thank you, guys. You can find me on all the social media outlets. Take good care, everybody.
Take good care. Be blessed.
Bye.
Bye. Be blessed.